Announcement. We are pleased to announce that the following 4 teams have scored the highest mark in ISA Midcon 2025 Prelims Quiz and have advanced to the final round, which will be scheduled today from 5:15 to 6:15 p.m. The finalist teams are Dr. Srishant and Dr. Sumi from Government Medical College, Calicut. Next is Dr. Harikrishnan and Dr. Litti Abraham. I request Dr. Srishant and Dr. Sumi to rise. Next, I request Dr. Harikrishnan and Dr. Litti Abraham from Government Medical College, Kannur to rise. Next, I request Dr. Avinash and Dr. Nimita from SUT Trivandrum to rise. Next, I request Dr. Namita Varghese and Dr. Ambli from John's Medical College to rise. All selected teams are requested to report at the registration counter by 5 p.m. today. Congratulations. Next, we have a long case presentation on chronic liver disease for lab cholecystectomy. Next, we have a long case presentation on chronic kidney disease for lab cholecystectomy by Dr. Anamika and Dr. Megha. The internal examiner will be Dr. Harikumar, professor at Government Medical College, Alappuzha. The external examiner will be Dr. Gurudutt sir, professor at JSS Medical College, Mysore.
Good afternoon, everybody, and you all know that chronic kidney disease is one of the common long case that is always kept nowadays, because probably in olden days we were not getting chronic kidney disease patients because dialysis was not there in every hospital. Now everywhere dialysis is there, and invariably we can get many patients on dialysis for our as long cases. So at least 2 or 3 chronic kidney disease may be there for you patients as long cases. So another very important thing here is why I am telling you this is many times we have the surgery, even other surgical specialties also on the same day as for our exams. So we'll not be getting many other cases. So easily we can get patients who are on dialysis as chronic kidney disease patients as long case. So invariably it will be there. Why I am telling is invariably it will be there, and you have to be very thorough with the long case of chronic kidney disease. So you can, you want to tell anything, sir?
You present the case first, sir. Okay.
Patient details. Kavita, a 42-year-old female from Alappuzha. She is a housewife. She presented with recurrent episodes of fever for past 2 months, vomiting for past 1 month, and abdominal pain for the past 2 weeks. History of presenting complaint. Complaint started 2 months ago when the patient noted recurrent episodes of low-grade fever not associated with any diurnal variation. It gets relieved on taking paracetamol. Patient also complains of non-projectile vomiting with the vomitus non-bilious or non-blood stained for the past 1 month, which worsened for the past 2 weeks. Patient experiences intermittent episodes of abdominal pain for the past 2 weeks, colicky in nature, which aggravates after the intake of food, relieved spontaneously, no history of any radiation of the pain. These symptoms were managed conservatively for the past 2 months. Patient is a non-case of chronic kidney disease, which was detected 5 years ago on evaluation for frothy urine, intermittent painless hematuria, swelling of face, hands and feet. She was on medical management initially, but for the past 8 months, she started taking hemodialysis. Hemodialysis was done through right IJV twice a week, but now it is done thrice a week through the AV fistula in the left forearm, which was placed after local anesthesia, and the procedure was uneventful. No history of decreased blood pressure, bleeding, itching, allergic manifestations, muscle cramps during dialysis. Last dialysis was done yesterday afternoon, 4 p.m., and now the patient is clinically better. No history of jaundice, no history of hematuria melina, no history of generalized pruritus, easy bruisability, no history of chest pain, dyspnea, palpitation or syncope, no history of muscle cramps, numbness, tingling sensation, no history of seizure, memory loss or altered sensorium. Past history, patient was diagnosed to have chronic kidney disease, IgA nephropathy, which was confirmed via renal biopsy 5 years back, following evaluation for frothy urine, painless hematuria, facial puffiness and edema. Patient is a non-case of systemic hypertension for the past 5 years. No history of diabetes mellitus, coronary artery disease, stroke, tuberculosis, asthma, chronic liver disease or psychiatric illness. No history of any drug allergy. No history of chronic analgesic use. No history of any blood transfusion. No history of any surgeries in the past. Effort tolerance. Patient is able to do standard house activities and she is able to walk 1 to 2 blocks at a speed of 3 to 5 km per hour. Drug history. Now the patient is taking telmisartan 40 milligram once daily, tab clonidine 100 microgram twice daily, tab atorvastatin 20 milligram HS, tab sodium bicarbonate 500 milligram once daily, tab calcitriol 0.25 microgram once daily, and injection erythropoietin 4000 international unit weekly once. Family history. No significant family history. Patient is having decreased urine output, normal bowel habits, mixed diet, decreased appetite and no additions.
General examination. Patient is conscious, cooperative, oriented to time, place and person. Height of the patient is 162 centimeter and weight after the dialysis is 64 kilogram and the BMI of the patient is 24.38. Mild pallor present and bilateral pitting pedal edema present. No icterus, cyanosis, clubbing, lymphadenopathy and an AV fistula is present in the left forearm. On vitals examination, pulse rate is 88 beats per minute, normal in volume and character, all peripheral pulses normal and condition of the vessel wall is normal. And thrill is present over the AV fistula in the left forearm. Blood pressure 140 over 96 millimeter of mercury in right arm in supine position and 130 over 70 millimeter of mercury in standing position. Respiratory rate is 15 per minute regular and it's thoraco-abdominal type. SpO2 is 99% in room air and the patient is febrile. Airway examination and spine, no loose tooth or artificial dentures. Temporomandibular joint mobile and insinuation of 1 finger is possible. Mouth opening is more than 2 finger breadth. Malambetti class 2 and thyromental distance is 7.5 centimeter and neck movements are normal and spine is normal. Gastrointestinal system, on inspection, no abdominal distension, umbilicus normal, no visible scars, striae or dilated veins. All quadrants moves normally with respiration and hernial orifices and external genitalia appears to be normal. On palpation, no guarding or rigidity, tenderness present in the right upper quadrant, no palpable mass or organomegaly felt. On percussion, normal liver dullness and no shifting dullness or fluid thrill. On auscultation, normal bowel sound hurts and no bruit. In cardiovascular system examination, JVP not elevated, scar of the right internal jugular vein catheter present in the right side of the neck, apex beat is palpable in the 6th intercostal space, half inch medial to the midclavicular line.
Is it half inch medial?
Half inch lateral to the midclavicular line.
Yeah, because the apex beat is already downward shifted. So whether it is shifted outwards, that also matters, and invariably if it is shifted downwards, majority of the times it is also shifted laterally also, isn't it? So it has to be half an inch lateral. So this is very important. So what do you think, why apical impulse is shifted downwards and outwards?
In CKD, patient will be having hypertension and there will be concentric and eccentric left
Isn't
ventricular
it? So that is
hypertrophy.
why when you are writing down or when you are presenting, it is very important to see whether you are writing down there or presenting to the examiner, whether it is medial or lateral. And another important thing I just observed is your airway examination. Don't say in finger breadths. You should always carry a 6-inch scale and also a tape. So 6-inch scale is always used for all these vertical distances like interincisor gap or thyromental distance, sternomental distance. Don't write fingers because whose fingers? Whether your fingers, patient's fingers, then it will be very difficult. Always be very accurate in the exam when you are presenting.
Then S1, S2 present and there is no murmur. Respiratory system, air
And don't say S1, S2 present, whether normally heard any abnormality you will have to tell. Don't say just present. They will be present, whether it is abnormal or normal, whether it's loud, whether it is any additional third out sound or fourth out sounds are there. So those things you will have to mention.
respiratory system, air entry bilaterally equal and fine basal crepitations present bilaterally. Central nervous system examination, higher mental function normal, no focal neurological deficit, sensor system examination normal, motor system examination normal, no signs of peripheral neuropathy. Summary, 42-year-old female who is a known case of stage 5 chronic kidney disease, presented with recurrent episodes of vomiting, fever, abdominal pain. On examination, patient is conscious, oriented with stable vital signs, mild pallor, bilateral pitting pedal edema present, and fine basal crepitations are heard on auscultation. Abdominal examination revealed tenderness in the right hypochondrium and is diagnosed to have acute calculus cholecystitis and is planned for laparoscopic cholecystectomy. Diagnosis, chronic kidney disease stage 5 on hemodialysis, posted for laparoscopic cholecystectomy.
No, you have taken a detailed history and also you have done a proper examination. So what positive findings in your history and in your examination are very important for the anesthetic management of this patient. Just 2-3 positive findings in history and 2-3 positive findings in the examination. Very important, very crucial for management of this patient.
Patient is a known case of chronic kidney disease who presented with symptoms of abdominal pain, vomiting for the past 2 months.
He is a known case of CKD. Okay, what else? For the past 5 years.
Now the patient is on hemodialysis through left AV fistula in the left forearm. And
When
now
the hemodialysis has been done. So that is one of the important history you have to elicit and you have elicited. Why it's important to know when hemodialysis has been done for your management of this patient?
to find the severity of chronic kidney disease.
To know whether there is patient is hypervolemic or euvolemic or hypovolemic, isn't it? So usually when suppose the patient is posted for today for surgery and the hemodialysis has been done 2 days before. So what you think as far as the volume status is concerned?
Patient will be hypervolemic. We should
Yes,
ask the patient to do a dialysis 24 hours prior.
Yeah, that is why you should know when the dialysis has been done. So what else in the history is important for you for the management of this patient, especially the drug history? That is another history. The third important thing during the examination, you have found out that there is basal cramps and also peripheral edema. So what does it suggest?
Patient is having fluid overload.
Yeah, maybe hypervolemic, isn't it? So patient doesn't have any, postural hypotension. So there is no question of hypovolemia. So these are some of the important, things in both history and examination you will have to keep for managing this patient.
So what is your plan of anesthesia here?
A plan of anesthesia is general anesthesia with a cuffed endotracheal tube with controlled ventilation.
So you are planning for this case for surgery and laparoscopy.
Okay, now you have diagnosed the patient is having chronic kidney disease for the past 5 years, isn't it? So how do you define chronic kidney disease?
Chronic kidney disease is defined as kidney dysfunction for 3 or more months, defined by structural or functional abnormality of the kidney with or without a decreased GFR, manifested by either pathological abnormalities or markers of the kidney dysfunction, including abnormality in the composition of the blood or urine or imaging studies, or it is defined as glomerular filtration rate less than 60 ml per minute per 1.73 meter square for 3 or more months with or without kidney damage.
So what are the causes of the chronic kidney disease?
Uh, Causes of chronic kidney disease include diabetes most common cause is diabetes mellitus followed by hypertension, and broadly causes of chronic kidney disease can be classified as glomerulopathies and tubulointerstitial disease. And glomerulopathies include diabetes mellitus, membranoproliferative glomerulonephritis, IgA nephropathy, systemic lupus erythematosus, and amyloidosis. And tubulointerstitial disease include analgesic nephropathy, reflux nephropathy, along with pyelonephritis, myeloma kidney, and other causes include polycystic kidney disease, renal vascular disease,
Which is the most common cause of chronic kidney disease?
diabetes mellitus.
Diabetes mellitus. And why should you know about these causes of kidney disease as anesthesiologist?
Causes and comorbidities can affect our anesthesia management.
How will you classify CKD, chronic kidney disease?
Chronic kidney disease is classified based on the glomerular filtration rate and also based on the albuminuria. Based on glomerular filtration rate, chronic disease is classified in 5 stages from G1 to G5. In G1, GFR will be normal or mildly increased, that is more than 90 ml per minute per 1.73 meter square. And in G2, it will be mildly decreased and will be 60 to 89 ml per minute per 1.73 meter square. And in G3, it is classified into G3A and G3B. In G3A, it will be mildly to moderately decreased, that is 45 to 59 ml per minute per 1.73 meter square. And in G3B, it will be moderately to severely decreased and is between 30 to 44 ml per minute per 1.73 meter square. And in G4, it will be severely decreased and will be 15 to 29 ml per minute per 1.73 meter square. And in stage 5, that is G5, there will be kidney failure and GFR will be less than 15 ml per minute per 1.73 meter square. And according to urine albumin, it is based on albumin excretion rate and also albumin creatinine ratio. It is classified into A1, A2 and A3. In A1, albumin excretion rate is less than 30 milligram per 24 hours, and in A2, 30 to 300 milligram per 24 hours, and in A3, it will be more than 300 milligram per 24 hours. And based on albumin creatinine ratio, in A1, it will be less than 30 milligram per gram, and in A2, 30 to 300 milligram per gram, and in A3, more than 300 milligram per gram.
Why do you have to know about the staging of the chronic kidney disease as anesthesiologist?
For risk stratification and to devise an anesthetic plan for the patient.
Plus, patients with more severe chronic kidney disease, for example, stage 3, stage 4, and stage 5 and all. So, majority of the pathophysiological changes would be very severe. And those pathophysiological changes, whatever that occurs because of the chronic kidney disease, you have to know. And, you have to manage your anesthesia or change your anesthetic technique and management accordingly. That is the reason why you have to know what stage the patient is. And when do you say patient is in end-stage renal disease?
When the glomerular filtration rate less than 15 ml per minute per 1.73 meter square.
So why should you know that patient may be in the end-stage renal disease?
These patients will be on dialysis.
Yeah, they require renal replacement therapy, either dialysis or even renal transplant surgery. Which one would be better? Early transplant surgery would be better, or continuous replacement with dialysis would be better for these patients?
Earlier transplant
Why
surgery.
early transplant surgery is always better?
It is associated with increased survival rate.
Of more than 70% in 5 years. When compared to patients on dialysis, the survival rate is just about 30% over 5 years. So that is the reason early transplant surgery is always better for these patients. Okay, now this patient will be taken up for surgery in another 2 days. So what investigations you would like to do for this patient?
Doing investigation, first I will do general investigations, including first is complete blood count, and in this first is hemoglobin.
Okay, what do you expect in hemoglobin in this particular patient?
There will be anemia.
No, do you expect anemia in this patient, or you expect, normal RBC or hemoglobin levels? Because this patient is already on a supplementation of erythropoietin. So maybe still patient will have anemia, because what is the maximum hemoglobin target you will always go for when you are supplementing these patients with erythropoietin?
10 to 11.5.
10 to 11, isn't it? So 10 to 11 grams of hemoglobin is still anemia or not anemia? When do you say patient is having anemia as such? For males, what is the, when do you say anemia, and for females when it is anemia?
Tell me the normal level. When
For males, less than 12, less than 14, and
Males less than 13 and females less than 12. And pregnancy less than 11 grams. So these are normal values. Sometimes when you say anemia, we'll be asking. So why not more than 11 grams you want to achieve in these patients by giving supplements with erythropoietin?
If we increases the level more than 11, viscosity of the blood will increase. That will, according to Hagen-Boisserle law, that will decreases the blood flow, and there is more chance for thromboembolic phenomenon and also thrombosis of the AV fistula.
Very good.
And there is also increased chance for hypertension.
Yes, sudden increase in the hypertension can occur if there is increase in the hemoglobin level to more than 12 grams. So our aim is only up to 11 grams. So in olden days, we never used to give erythropoietin supplementation or even blood transfusion for increasing their hemoglobin level. So we were even accepting these patients at 6 or 7 grams of hemoglobin. So why we were accepting those days, and why we want to optimize the hemoglobin level nowadays?
Although there is anemia, it is a compensated anemia. So anemia,
Why it's compensated anemia, you say?
it is compensated with increase in
No,
cardiac
because of chronic anemia.
anemia.
It is not an acute anemia where compensation will not be there. It's a chronic anemia, so well compensated. So what are the compensatory mechanisms that will be there for?
There will be increased cardiac output. So it will be a hyperdynamic circulation, and also there will be decreased viscosity, so that it can increase the microcirculation, and also there will be increased acidosis, and increased 2,3 DPG can shift the oxygen dissociation curve to right, so there will be more release of oxygen to the tissues.
So that is the reason why we were not. And the availability of erythropoietin, synthetic erythropoietin was not easily available. So that's the reason why we were somehow accepting. Now since it is available, and we can always achieve a hemoglobin level of 10 to 11 grams. So what are the causes of anemia in this patient? Why do they go for anemia?
Decreased production of erythropoietin from the kidney, and
Okay.
also there will be decreased lifespan of red blood cells, and there will be nutritional anemia due to decreased dietary intake of iron, vitamin B12 and folic acid, and also due to secondary hyperparathyroidism, there will be bone marrow fibrosis will be there,
Okay.
and also due to dialysis there will be more blood loss will be there.
Repeated dialysis. More damage to the RBCs. Not blood loss, more damage to the
And there will also be direct damage to the bone marrow suppression will be there due to uremia.
Plus, gastrointestinal bleeding can occur because of,
Uremic bleeding will be
plus the platelets.
platelets.
There is a dysfunction of the platelets. What dysfunction of the platelets will be there in these patients?
Qualitative dysfunction of the platelet occurs in chronic kidney
What
disease.
qualitative dysfunction? Why?
Production of the von Willebrand factors and fibrinogen from the alpha granules of the platelet will be affected.
And factor 8 and 1 Willebrand factor inside the platelet is affected. So there is a qualitative deficiency. Quantity will be normal. So that is why there is a decreased aggregatory, property of these platelets. So that's how, there can be, if bleeding occurs, there can be prolonged bleeding. That can also be one of the causes for anemia. Okay, what other investigations?
Then I will do WBC count, as these patients are more prone for infection due to as they are immunosuppressed.
why TC and DC should be done?
The patient will be more prone for infection, and also they are in immunosuppressed state.
And in chronic kidney disease, there will be decreased humoral and cell-mediated immunity in these patients.
And plus these IgA patients, sometimes they may be on corticosteroids and other immunosuppressives also. So though this patient is not on that. Okay. Right. Other investigations.
Then I will do platelet count. Then I will go for renal function test, serum
Now,
electro.
before that, still general investigations, you could have done an ECG for these patients.
I will do ECG for
Why
this patient.
ECG for this patient? How old is the patient?
42-year.
Yeah, just not very old, that to female, 42-year-old. Still you want to do an ECG for this patient?
Yes, I will do ECG for the patient because in chronic kidney disease, patient will be having left ventricular hypertrophy and they are more prone ischemic heart disease. There is electrolyte, so they are more prone for development of the arrhythmias.
No, one thing is, are they prone for accelerated atherosclerosis?
Yes.
Why they are prone for accelerated atherosclerosis?
Because since there is a chronic inflammation, there will be endothelial dysfunction, so there is more chance for plaque formation.
Endothelial damage will be there and more chances of plaque formation. Plus
There will be
deposition of calcium
calcium
also,
also.
isn't it? So that is why they are, one thing is they have accelerated atherosclerosis. As you are telling again, because they are hypertensive patients, invariably because of that concentric hypertrophy of the left ventricle will be there and left ventricular compliance will be less. So naturally the left ventricular end diastolic pressure will be high. So naturally the supply of blood flow to the or coronary oxygen supply is affected, plus the demand is high. So invariably these patients will have atherosclerosis and coronary artery disease, and many times they die because of the coronary artery disease rather than because of the kidney problems. So that is why it is very important to do an ECG. Plus the other important things about ECG, you are also telling about electrolyte imbalance. Is what electrolyte imbalance they can have and you can find out from the ECG.
There can be hyperkalemia. So hyperkalemia depends upon the level of serum. ECG manifestations of hyperkalemia depends on the level of serum potassium. It can be mild, moderate, and severe. In mild hyperkalemia, serum potassium is between 5.5 to 6.5, and there will be peak T waves will be seen. And
usually it starts after 6.5, isn't it? Tall T waves, tall peak T waves. What other ECG findings you can see?
In moderate hyperkalemia, 6.5 to 8, there will be prolongation of QRS,
right?
ST segment elevation.
What happens to the PR interval?
PR interval also prolongs.
Prolonged, okay. After 8.5?
After 8.5, there is increased chance for ventricular fibrillation,
With sine wave pattern, isn't it?
Asystole.
Anyway, ECG is very important to know about the electrolyte imbalance also. Like even they can have hypocalcemia also. So what ECG finding will be there in hypocalcemia?
ST depression.
No, prolonged QT interval, isn't it? So hypercalcemia is short QT interval and prolonged QT interval in hypocalcemia. So there can be even other electrolyte imbalance also. So one, you said the potassium imbalance. Why potassium hyperkalemia can be there in these patients, and that is more important for us.
Here there will be decreased potassium excretion, and also there will be intracellular to extracellular shift of potassium ions, and also there will be increased potassium intake from drugs and then due to blood transfusion.
No, what drug in the patient is already taking can increase potassium levels?
ARBs.
ARBs and AC inhibitors, isn't it? Why ARBs and AC inhibitors can increase the potassium level? How they increase the potassium? What is the effect of angiotensin 2 on aldosterone metabolism or release? Will it increase the aldosterone release?
It will decrease.
Angiotensin 2 stimulation will increase the aldosterone. Aldosterone will excrete potassium, retain sodium normally. So when they are blocked, aldosterone secretion is decreased. Now sodium excretion increases, potassium retention. That's how hyperkalemia can be there, can occur. Okay, what other investigations you would like to do?
Then I will do echocardiography to know the ejection fraction, any regional wall motion abnormalities, any pericardial effusions.
And also systolic and diastolic functioning of the left ventricle you have to assess, isn't it? Because invariably these patients may have a diastolic dysfunction. And why diastolic dysfunction is also important for you to know about, especially in these patients. What anesthetic importance as far as diastolic dysfunction is concerned?
Because the patient in chronic kidney disease, patient is having hypertrophy of the left ventricle. the muscle fibers cannot relax properly, so there will be diastolic dysfunction of the patient. And when there is diastolic dysfunction, there will be left atrial hypertrophy and left atrial enlargement, left atrial dilatation. This can cause arrhythmias.
Yeah, they'll be highly prone for intraoperative dysrhythmias, especially atrial fibrillation, plus the pulmonary edema, the back pressure effects. So that is why systolic function also may be affected because of the coronary artery disease. Diastolic dysfunction also may be affected because of both eccentric and concentric hypertrophy. Why eccentric hypertrophy also can be there in these patients?
Due to pressure overload.
Yeah, volume overload. Volume overload. Okay. Any specific investigations you would like to do?
Yes, I would like to do serum electrolytes, then renal function test, liver function test to know the baseline level. Then
Renal function test, which renal function test you would like to?
I will do blood urea, serum creatinine.
So which one will be more important, whether serum creatinine or blood urea?
Serum creatinine.
Serum creatinine. Yes, okay.
Any test in the urine base?
Yes, I will do urine albumin, then fractional excretion of the sodium.
Okay. You know the importance of fractional excretion of sodium. Why it's important? How it is given the report? Is it in percentage?
Yes, it is given in percentage.
Yeah. If it is less than 1%, what do you think? If it is more than 2%, what do you think? Fractional excretion of sodium. Normally functioning kidney can concentrate sodium, isn't it? So it will be less than 1% if it is everything is normal. If it is more than 2%, you can always think that there is a renal damage is there. In these patients, there can be, if urine you can assess for fractional concentration of sodium, it will be abnormal. It will be more than 2%. Whenever there is a fractional concentration of sodium is abnormal, other electrolyte abnormalities also will be there. Like you can have sodium, calcium, potassium, calcium, magnesium, phosphate, everything can be there. Other electrolyte imbalance. Okay, you have done most of these investigations. You know that these patients can have hyperphosphatemia. They can have hypocalcemia as well. Now, you have to prepare the patient for surgery. How do you prepare the patient for surgery?
Pre-optimization of the patient should be carried out by correction of the fluid electrolyte abnormalities, which can be done by dialysis, and then the correction of anemia. Anemia can be corrected by giving erythropoietin.
Okay, very good.
Injection erythropoietin 50 to 150 international unit per kg, twice or thrice weekly can be given. And then dabopoietin alpha can also be given. And then by correction of anemia, we can increase hemoglobin by 1 gram over 4 weeks.
Okay. Okay, then what other preparations?
Correction of bleeding, uremic bleeding can be corrected by giving desmopressin. We can also give conjugated.
That usually you don't give before surgery. You can keep it ready for intraoperative use. Okay, so now you have prepared the patient. Now the patient is posted for lap cholecystectomy tomorrow morning. So you are going to visit the patient today evening. So what all the things you will ask the patient and what all the things you will be telling the patient?
On the day before surgery, I'll make a good rapport with the patient. I'll explain the procedures and the plan of anesthesia to the patient. And I'll also make sure that the patient do a preoperative dialysis, ideally 24 hours before surgery, and there should be 6 hours time lapse between the surgery and dialysis.
Why this 6 hours gap?
Because before 6 hours, patient will be more chance for hypovolemia.
Yeah, within 6 hours, one is hypovolemia. What other problems?
If they are not doing heparin-free dialysis, we should take twice the half-life of heparin.
So another problem is, again, the patient may have more bleeding intraoperatively because of the effect of heparin. So ideal would be 6 hours gap should be there, but within 24 hours to see that there is euvolemia for the patient. Okay, then
I'll obtain an informed high-risk consent from the patient, and then I'll explain the NPO guidelines, 6 hours for solid food and 2 hours for clear fluid, and I'll also make sure that the patient takes continue ongoing medication.
No, other than these, would you like to give any medication to see that he will not have any aspiration intraoperatively?
Yes,
is the intraoperative aspiration chances are high in these patients?
Yes, sir.
Why?
There will be delayed gastric emptying in patients with chronic kidney disease.
Why? Because of autonomic neuropathy. They may have peripheral neuropathy and autonomic neuropathy. So that is the reason. So you have to take all precautions to prevent aspiration, isn't it? So aspiration prophylactic drugs you have to give,
Yes.
right? Then
I'll ask the patient to take tab Rantac and tab metoclopramide 10 milligram
Okay.
on day before surgery and 20 minutes before on day of surgery.
okay, all other drugs that the patient is already taking, would you continue?
Yes, sir. I'll ask the patient to continue all the
AC
drugs.
inhibitors also?
Yes, yes, sir.
No, because this is not a surgery wherein there is not lot of fluid shifts. So it is always better to continue AC inhibitors or ARBs for this patient. And the patient is taking these drugs, though of course for hypertension. If the patient is taking these drugs for cardiac failure, definitely would continue. But even for hypertension, he will continue because there is not much of fluid shifts, not much of problem as far as intraoperative hypotension is concerned because of these drugs. And invariably these patients, for laryngoscopy and all, there is going to be a very strong sympathetic response. So by continuing these drugs, you can definitely maintain, normotension throughout the surgery. Okay, so you are going to continue all the, how about statins?
Continue on.
You will continue statins also. Okay.
And I'll ask
Right.
the patient to do an RFT, serum electrolytes, and a CPC on day of surgery,
Okay.
post dialysis.
How do you induce this patient? Because you have already planned for general endotracheal anesthesia. How do you induce?
Rapid sequence induction should be done.
Why rapid sequence induction? Already just now discussed because full stomach.
Full stomach
Okay. So what pre-induction drugs you would be giving for this patient to prevent suppression of the intubation response?
We can give 60 milligram of 2% preservative-free lignocaine intravenously 90 seconds prior to laryngoscopy and intubation. We
Right.
can also give esmolol 0.5 milligram per kg IV.
Any
before-
problem because of a beta blocker in this patient? Can it increase potassium levels?
Yes, sir.
Yeah, so that you may have to think twice. Okay, one is lidocaine. How about fentanyl midazolam?
Yes, sir. I'll give injection midazolam 1 milligram IV. Then I'll give injection glycopyrrolate 0.2 milligram IV. Then injection
Glycopyrrolate, why unnecessarily? There is no requirement, isn't it? So glycopyrrolate can produce more problems as far as even heart rate can increase. So unnecessary drug therapy will not give. So we have to suppress this intubation response of hypertension and tachycardia. So definitely midazolam in a lower dose you have to give, because midazolam, again, the metabolite of midazolam has to be excreted through kidneys. So that you have to take care. How about dexmedetomidine in this patient as a pre-medicate?
dexmedetomidine can be
You can give. So it won't require kidney for its excretion, and metabolites also will not require kidney for their excretion. Okay, now.
So this is the laparoscopic surgery. What are the anesthetic concerns regarding this patient, especially this patient?
So since it is a laparoscopic surgery, there will be problems when the placement of trocar. There will be chance for bowel and bladder injury, and also there will be extra abdominal insufflation of the gas, and then there will be problems due to the creation of pneumoperitoneum. We should maintain intra-abdominal pressure between 12 to 14 millimeters of water. We should avoid increased intra-abdominal pressure. If there is increased intra-abdominal pressure, it can cause this endobronchial cephalosis.
More important in a patient with CKD.
There will be cardiovascular and respiratory system, and there will also be renal vasoconstriction, which can reduce.
No, there can be compression of the aorta and inferior vena cava, isn't it? So that is one problem. Another problem is, precautions as far as the AV fistula is concerned. You have to be extremely careful. You don't apply the sigmoid cuff on that side, and all IV lines to be taken only on the dorsum of the hands. You don't use the forearms for getting an IV line. So it's another important thing. You'll have to keep it in mind. And using muscle relaxants for intubation. Which muscle relaxant you will be using for intubation?
We'll go for succinylcholine if serum potassium levels are below 5.5 milliequivalents per liter.
Okay. For maintenance?
We can give injection atracurium or cisatracurium for the patient.
Okay. You don't want to use vecuronium or rocuronium, aminosteroids. Why?
the metabolite of vecuronium, 3-hydroxyvecuronium, is having renal excretion, so effect will be prolonged in patients with chronic kidney disease.
Even vecuronium 50% excreted through kidneys unchanged. And rocuronium 25% of it is excreted unchanged through the kidney. So they can have a prolonged duration of action. Even if you want to reverse with Sugammadex, again Sugammadex is contraindicated in patients with less than GFR less than 30 ml per minute GFR. It is usually contraindicated. So that's the reason why you don't want to go for aminosteroids. Okay, any problem with even cis-atracurium or atracurium? Atracurium mainly.
Have Hoffman elimination, and also
So the metabolite.
And the metabolite laudanozin can cause seizures.
Laudanozin can accumulate, isn't it? Because it requires kidney for its excretion. Okay.
What is the Hoffman elimination?
Hoffman elimination is a pH and temperature dependent elimination of atracurium.
Okay, the surgery is over. Fortunately, no complications. And how were you managing intraoperative fluids and monitoring the patient? That we did not discuss because of lack of time. Monitoring, do you require any invasive monitoring in this patient?
No invasive monitors are required.
But non-invasive, what important monitor you require to have?
Pulse variability index.
Pleth variability,
index.
That is mainly for
Volume.
intraoperative fluid correction.
Any
Fluid
criteria?
response.
Any criteria?
If it is greater than 13, we can give bolus fluid to the patient.
Okay, how do you reverse this patient?
We can reverse the patient with neostigmine and glycopyrrolate.
Any problem with neostigmine and glycopyrrolate in chronic kidney disease patients?
Neostigmine, it is 50% excreted through the kidney, so the effects can be prolonged. But for the patient, there will not be any residual neuromuscular blockade after reversal.
Yeah, it's an advantage because anyway, both are going to be prolonged. Both are excreted through kidneys by 50%, both neostigmine and glycopyrrolate. So that is an advantage. What post-op analgesia you would plan for this patient?
We can give injection paracetamol and then injection fentanyl. We can keep an infusion of 20 to 25 microgram per hour. Then we should avoid NSAIDs for the patient.
Can you use tab block also?
Yes, sir, we can.
Can use tab block also. Any problem with local anesthetics in chronic kidney disease patients?
Local anesthetics are basic drugs and they are bound to alpha-1 acid glycoprotein. And alpha-1 acid glycoprotein is increased in chronic kidney disease. So dose reduction is required for local anesthetics. And also local anesthetics acts in
No, because metabolic acidosis is very common because hydrogen ion is not excreted, bicarbonate is more excreted in these patients. Invariably, they'll have metabolic acidosis. Any metabolic acidosis and local anesthetic onset of action?
it will delay the onset of action
Why
of the local anesthetics.
onset gets delayed? Because the pKa, isn't it? Even lidocaine pKa is 7.8 and bupivacaine is 8.2. In all patients with acidosis, more amount of ionized quantity of these drugs will be there. So onset gets delayed. So that you have to keep it in your mind while providing any regional anesthesia in this. Why not regional anesthesia for these patients? Why not combined spinal thoracic epidural with now people are practicing segmental spinal.
In chronic kidney disease patients, there is renal osteodystrophy, so there will be increased chance for vertebral fractures during positioning, as well as while advocating epidural anesthesia, there is more chance for vertebral fractures.
So you have to be extremely careful in positioning the patient also, even if you want to go for regional anesthesia, because the bones will be very brittle. Okay. So anything else?
What all complication here, post-operative complication you are anticipating in this case?
Post-operative complications for these patients can be due to anesthesia related and due to surgical related and laparoscopy related. Laparoscopy related, there will be increased chance for gas embolism, thorax pneumomediastinum, and also there will be delayed recovery from anesthetic drugs, and there is also more chance for DVT and positioning injuries can be there.
So intraoperative hypotension, intraoperative DVT chances will be high. Plus, as you said, that the delayed recovery, because majority of the drugs require kidney to be excreted. Okay, thank you.
Okay, thank you.
Anything, sir? Thank you very much.
Thank you, doctors. Now, I request Dr. Gurudutt sir to kindly distribute the participation certificate to Dr. Anamika and Dr. Megha. Now, I request Dr. Manjit to please come onto the stage to felicitate Dr. Harikumar. I also invite Dr. Akka Mahadevi to please come onto the stage to felicitate Dr. Gurudutt sir. Delegates, please